Everyone, my name is I am one of the T32 cardiology fellows. It is my honor to introduce Dr. Susan Wolver for today's Grand Rounds talk. Dr. Susan Wolver, she graduated from Wake Forest Medical School after serving 10 years as an Air Force flight surgeon. She came back to do residency in internal medicine at BCU. She stayed on as faculty primarily in primary care and medical informatics. She became board certified in obesity medicine 2014 and is the inaugural director of the BCU Medical Weight Loss Program, now in its 11th year. Really big kudos to you, Dr. Wolver. That's incredible. She and her team have helped more than 3,000 patients lose weight and improve their health. She's passionate about delivering evidence-based and compassionate care to those suffering from the disease of obesity, and equally passionate about teaching colleagues and the next generation of physicians that how to treat this life-altering disease. So without further ado, I'd like to welcome Dr. Wolver. Thank you.
Thank you so much for having me. These are my objectives, but we'll go ahead and get started. I have no disclosures. I'm not a rich cardiologist, just kidding. So this is what we're going to talk about, the disease of obesity, the new highly effective injectable anti-obesity medications. We'll talk about emerging indications for them and how you can select appropriate patients and follow them. Hopefully I'll leave a little extra time because I know there are going to be lots of questions. Why should you care about obesity, these medications? Well, the problem of obesity is massive, and we all have to be a part of the solution. And treating obesity is and will increasingly become a part of many guidelines for many of the things you treat as well. And if you see patients before they have a lot of these complications, you can be really helpful in helping to prevent them. Patients with obesity have a 50 to 100% higher risk of death from all causes compared with normal weight individuals, and most of the increased risk is due to cardiovascular disease. So this just came out, you'll see, days ago. I've given many presentations this year about this topic specifically, and each time I give it, there's brand new something or another to talk about. So this just came out in the European Heart Journal, and it is a wonderful reference. I gave you the whole reference down there. It's very comprehensive, and I really suggest everyone take a look at it. And in this, they talk about actually one of the new injection medications has a class 2A evidence for treating people. And we're actually going to talk about this specifically later on. This is where I grew up in Brooklyn, New York. This is when I actually lived there. And if you look long and hard, you'd be very hard pressed to find a single person with overweight or obesity. Fast forward to when I went on a cruise right before the pandemic, and I thought I was taking a picture of the beautiful scenery in St. Thomas. And when I came home and I was looking at my pictures from the cruise, I was really struck by the fact that if I looked long and hard, I'd be hard pressed to find a single person that did not have overweight or obesity. And even those who look thinner seem to have that visceral adiposity. And of course, the statistics say the same, that obesity rates have tripled over the last 60 years. And right now, 75% of our country has overweight or obesity. And when we say obesity, what do we mean? Of course, we're talking about the BMI, the body mass index. Now, the body mass index is only, you can see from this calculator here, height and weight. So it's very easy to capture. And of course, our EPIC EMR captures that. But when we're talking about a normal BMI, we mean that people are at low risk for obesity-related comorbidities. So generally, we're speaking about a BMI of 20 to 25 being a healthy weight, 25 to 30 being overweight, 30 to 35 class 1 obesity, 35 to 40 class 2, and anything 40 or more is class 3 obesity. However, because it only captures height and weight, it's not a perfect measurement of health. So it doesn't take into account things like age or gender, ethnicity, or muscle mass. So it's a better measure for populations and less of a good measure for an individual sitting right in front of you. However, there are some populations that it doesn't fit well either. So we know that people of Asian descent actually have to have a lower BMI to have low cardiometabolic risk. Black females can actually have a higher BMI. Those with a muscular build oftentimes have a higher BMI, but are cardiometabolically healthy. We also know that older adults, and of course that number keeps getting older the older I am, but technically that's 65 or older, we actually prefer them to be in the overweight category because we know that if they get sick or have to have an operation or be hospitalized or get cancer, they actually have less morbidity and mortality if they are in the overweight category rather than in the normal BMI category. And of course, you all know this, you see this every day, the impacts of obesity. Most of the chronic conditions we see are very directly related to obesity. But let's look specifically at the cardiovascular consequences of obesity. This actually comes from that European Heart Journal. The cardiovascular risk factors of diabetes, hypertension, dyslipidemia, and sleep apnea, coronary artery disease, peripheral arterial and cerebrovascular disease, HFpEF and HFrEF, atrial fibrillation, sudden cardiac death, DVT, PE, and aortic valve stenosis. And our decades-old advice of eat less and move more doesn't work. And why is that? Well, first of all, exercise doesn't help you lose weight. Exercise is critically important to good health, but it is not very effective at weight loss. That's really diet. Even adding exercise, even adding intensive exercise to diet helps very little. Exercise is probably much more important in weight maintenance than it is in weight loss. The other reason this advice doesn't work is because we're so much more than calories in and calories out. In fact, obesity is a very complicated hormonal disease. It was actually classified as a disease by the AMA in 2013, so 11 years ago, and the Obesity Medicine Association defines it as a chronic, progressive, and relapsing disease. There are many guidelines as to how to treat obesity, but all at the foundation have the same thing: lifestyle modification. And lifestyle modification can give you about a 5 to 10% weight loss. That may not seem like much, but it can actually help all these weight-related comorbidities right here. But unfortunately, most people regain their weight in about the first year. And why is that? It's because of metabolic adaptation. So the sad truth is that as we lose weight, our bodies will fight us to regain it. So our metabolism will slow and we will get hungrier. So that's why obesity pharmacotherapy can be a very useful adjunct. Who is a candidate for obesity pharmacotherapy? People with a BMI of 30 or more, or 27 with a weight-related comorbidity like diabetes, hypertension, MASLD, or sleep apnea. They are all teratogenic, or there are no studies proving their safety. And they are contraindicated or cautioned in certain eating disorders. The first anti-obesity pharmacotherapy, also known as AOMs, was actually introduced as early as 1959, which was phentermine, which is a stimulant, and we still use it today. And then medications came on the market and off the market and on the market and off the market. And then it wasn't until about a little over a decade ago that we got this combination therapy. And you can see that these actually are fairly successful. We're having double-digit weight loss here. However, despite the success with these medications, the uptake was very low. So less than 0.5% of eligible population used the oral AOMs in 2018. So enter the era of highly effective injection anti-obesity pharmacotherapy. And you can see here, this is a comparison now about how much more effective these in fact are. And everyone's talking about them. You know, if Oprah's talking about them, everyone's talking about them. And if you haven't seen her special, I would ask that you actually go back and look at it. I think there were some problems, but I think mostly it was a very, very good presentation. And Weight Watchers, which is more than 60 years old, this past year actually introduced for the very first time medications, specifically the injection anti-obesity pharmacotherapy. So let's go back to this very complicated disease we talked about and focus in on these GLP-1s, known as glucagon-like peptide 1, that are produced by the small intestine. GLP-1 has many effects on many of the organs of the body, but we mostly think about its effects on the GI tract as slowing gastric emptying, increasing insulin release, but there's also an amazing effect on the brain. People who take these medications all say, wow, I have so much less food noise. So let's talk about the three medications that have been approved for obesity, these injection anti-obesity pharmacotherapy. All three of them were actually approved for diabetes before they were approved for obesity. So the first one was liraglutide. For obesity, it's known as Saxenda, and for diabetes, it's known as Victoza, but the dose for diabetes is less than the dose for obesity. So it was FDA approved for obesity 10 years ago in 2014. It is a daily dosed injection medication, which is increased weekly to a maximum dose of 3 milligrams. And the maintenance dose is 3 milligrams. And you can see people in the studies at the maximum dose were able to lose about 8% of their body weight. The next medication to be approved was semaglutide, known as Wegovy for obesity and Ozempic for diabetes. Also, again, the dose for diabetes is less than the dose for obesity. So approved just 3 years ago, it is a weekly dosed medication, which is increased monthly to a maximum dose of 2.4 milligrams. The maintenance doses are listed as either 1.7 or 2.4 milligrams. And in the studies, they were able to achieve a 15% weight loss at the maximum dose. The next injection anti-obesity pharmacotherapy is not just a GLP-1 receptor agonist, but it is a dual receptor agonist, both GLP-1 and GIP. GIP is glucose-dependent insulinotropic polypeptide. It has some similar actions to GLP-1, but also some opposing actions, specifically glucagon. So this first dual peptide receptor agonist, tirzepatide, actually is the only one that has the same dose for diabetes as it does for obesity. For diabetes, it's known as Mounjaro. For obesity, it's known as Zepbound. For obesity, it was only approved in November of last year. It is also a weekly dosed medication, which is increased monthly to a maximum of 15 milligrams. The maintenance doses are 5, 10, or 15 milligrams. And in the studies at the maximum dose, participants were able to achieve about a 21% weight loss. Now you'll see I have this comment here, and it says, if on oral contraceptives, need a second form of birth control until at a stable dose for a month. That's going to be 7 months if you go to the maximum dose of using a secondary form of contraception. Now you wonder, well, why is this here for tirzepatide and not semaglutide? And that's because tirzepatide did the studies during the dose escalation, where semaglutide did the studies at dose maintenance. So I believe that both semaglutide and tirzepatide patients should be using secondary protection until they are at a stable dose. So let's talk about the contraindications for these medications. So that would be pregnancy and patients with a history of pancreatitis or a personal or family history of medullary thyroid cancer or MEN2. I tell my patients that the benefits of these medications are reduction in appetite, cravings, blood sugar, but not to an unsafe level, weight reduction, and there's emerging evidence or increasing evidence that it's beneficial for liver, kidneys, and heart. Most people will get some GI side effects: nausea, vomiting, constipation, diarrhea, gallbladder disease, GERD, small bowel obstruction, gastroparesis, anorexia. Other side effects include hypersensitivity reactions at the injection site, tachycardia, renal impairment, but that's really from the vomiting and diarrhea that you might get, not a direct effect. Hypoglycemia, well, of course, they were diabetes medications first. Increased risk of fracture, so I get a little pause as patients get older. Worsening retinopathy, but that happens anytime you get rapid blood sugar control, even with insulin. There have been some case reports of increased thoughts of self-harm. And then pancreatitis and thyroid cancer. Remember, those were contraindications. Now I have references for all these things you can see here at the bottom. But in post-marketing meta-analyses in patients that are using these medications for diabetes, remember that was much earlier, so we have more information, there does not appear to be an increased risk of pancreatitis or thyroid cancer. Now, if that's going to be true in patients without diabetes, that remains to be seen. You know, it's interesting, as I keep giving these presentations, the list of side effects, I'm now on a second slide. So there's this very, very rare eye disease, a cause of eye blindness called non-ischemic anterior optic neuropathy. Again, it's very rare, but they did find that people on semaglutide seem to have it more. Also just came out here on the bottom, and Jack, you can see in April of this year, is there more dysautonomia on these drugs? And actually, they were only looking at the first two, liraglutide and semaglutide. So there does appear to be a small incidence of dysautonomia, but more studies are needed. This was just observational. Okay, some additional considerations. So I said most people will get some GI side effects. So how might we be able to help them overcome the GI side effects? So this is a really great article, and there's actually a patient handout, even though it's British, so some of the words are a little funny. But I actually will hand out this to patients if they are having trouble. So things like eat slowly, smaller portions, reduce fat.
Back to this schedule.
Don't use a straw, PRN anti-nausea medication. So I do not hand out the medication with a prescription for Zofran. I want to know if my patients are having trouble. And if they are, we're going to talk about how not to have trouble. And in the probably more than 1,000 of these medications I have prescribed, I've only handed out Zofran, I think, twice. And that will only be temporary. I will not continue a patient on Zofran so they can tolerate these medications. If they're having trouble, you may need to reduce the dose, switch. For most people, I find that tirzepatide is better tolerated than semaglutide, but actually for some people, it's the exact opposite. So it's very individual. And then there's some people that will not tolerate this class of medications at all, and so we will have to stop. If patients miss more than 2 doses, they have surgery or their insurance company, they have to switch pharmacies or something, or they can't find it, you may have to reduce to a previous dose or start at the initial dose again. Patients need to stop 2 months prior to conceiving. These are very long-acting medications, and it's been shown to have fetal toxicity in animal studies. Not recommended in breastfeeding. There's a possible increase in muscle mass loss. You already lose muscle when you lose weight, no matter how you lose weight, but you may lose more muscle with these medications. So again, it gives me pause in much older adults. And whatever kind of therapy you're giving a patient for their obesity, if it's not effective and they're not losing weight, then you want to discontinue it. So discontinue if they haven't lost more than 5% of their body weight at 3 months or at maximum dose of the medication. And patients need to understand that these are long-term medications. And why is that? Well, obesity is a chronic disease and we need to treat it as such. And current evidence shows when we stop these medications, there can be a rapid weight regain. You also need to tell your patients, if you are the prescriber, that if they're going to be having a procedure, that they will need to hold the medication. So these are anesthesia guidelines. And they say that if the patient is on the daily dose medications, they should hold on the day of the procedure. If they're on a weekly dosed medication, they should hold the week prior to the procedure. And that's regardless of whether they're taking it for diabetes or obesity or the type of procedure or surgery. And then we had talked a little bit about this already, but there's all over TikTok Ozempic babies. So these drugs, when you lose weight, you actually become more fertile. There's some indication that these drugs by themselves may help you to be more fertile. And then I told you that the absorption when you're dose escalating of oral contraceptives can be reduced. So it's very important that you relay this information to your patients. If they do get pregnant, there are FDA registries for the 3 different medications that you can add your patients to. So the next point I'd like to illustrate with a case. So this is was actually in JAMA Internal Medicine, a 62-year-old male patient with class 3 obesity, hypothyroidism, and type 1 diabetes. He was actually started on tirzepatide at 2.5 milligrams and told to up titrate monthly. So this is what some people are doing. They're sending all the doses to the pharmacy, and then they tell the patient each month get the new dose at the pharmacy. Now, the patient was supposed to have a follow-up in 1 month, but he missed it. He presented to the emergency room with palpitations, excessive sweating, confusion, fever, and hand tremors. At that time, he had been on 10 milligrams of tirzepatide with a whopping 36-kilogram weight loss in 6 months. He was found to be in atrial fibrillation with thyrotoxicosis. So when your patients are on medications, some of them other medications need to be closely monitored in patients with rapid weight loss. So things that have weight-based dosing like insulin, levothyroxine, like our previous patient, anticoagulants, anticonvulsants, TB meds, antibiotics, and antifungals. You also need to look at medications that have a narrow therapeutic index like warfarin, digoxin, tacrolimus, cyclosporin. Those are medications I thought that you might use more often than the others. And then, of course, as we talked about already, medications with possible absorption problems. So it's not just prescribing these medications, but thinking about the other medications that the patients are on. I told you that GLPs overall affect many of the organ systems of the body. And so I'm sure it's not a surprise that we are looking at these medications for many different conditions, things like depression, Alzheimer's, substance use disorder, and that is for things like opiates, alcohol, even tobacco use. And even if you're not prescribing it for those indications, your patients will tell you, yeah, you know what? I'm not drinking alcohol anymore, or I was finally able to quit smoking. Parkinson's disease, metabolic associated steatotic liver disease, MACE, HFpEF, sleep apnea, and polycystic ovarian syndrome. And I've actually given you, if you're interested, the references to all of these, but we're going to do a little bit of a deeper dive into just a few of them, ones that specifically affect cardiologists. So MACE, major adverse cardiac events. So there was a pivotal article in the New England Journal at the end of last year, and this was looking at semaglutide and cardiovascular outcomes in obesity without diabetes. Now, we have known that semaglutide has a beneficial effect in patients with diabetes, but this is the first study to show that it has a beneficial outcome in patients with known cardiovascular disease and obesity, but without diabetes. And what they saw was a reduced risk of composite death from cardiovascular causes, non-fatal MI, or non-fatal stroke by 20%. And this is really pivotal because earlier this year, the FDA actually gave this new indication for the weight loss medication Wegovy or semaglutide. And Medicare has never been able to actually cover anti-obesity pharmacotherapy because it is actually prohibited by law. So this came out when, I don't know, some of you who are older and have gray hair like me, fen-phen was on the market many years ago. It was a fantastic weight loss drug, but what they didn't realize is it actually caused some valvular damage, and so it was taken off the market. And so because of that, and because of at that time, obesity was thought to be a cosmetic disease, Medicare put into law that they would not cover obesity pharmacotherapy. But because of this, because of what happened earlier this year in the new FDA approval, Medicare and Medicaid now actually are providing coverage for this medication with patients who have known cardiovascular disease and overweight or obesity. All right, let's move on to HFpEF. So also in the New England Journal at the end of the year was the results of the STEP HFpEF trial. And what they saw was people who had HFpEF who were on semaglutide, they had a very significant improvement in their symptoms and their Kansas City cardiomyopathy questionnaire. More so, in fact, than any other medication ever used for the treatment of this condition. And we fully expect that this will also be an FDA-approved indication, probably at the beginning of 2025. And for me, that's really great because I see far more patients that have this than actually have known cardiovascular disease, because I see more women and more women have this problem. But if we're talking about heart failure, we of course need to talk about the obesity paradox. I'm sure most of you cardiologists have heard about that. And actually, somebody that I work closely with, Dr. Patel, and I have a patient that we've discussed this at great lengths, because we had a patient with HFrEF that we were concerned, should we help her lose weight or not, because of this cardiovascular, this obesity paradox. So this came from a study in 2002 that showed, and I have the study there on the bottom, that after 1 year of follow-up of patients who have had a PCI, the mortality was actually higher in patients with a normal BMI compared to those with overweight or obesity. But I think subsequent studies have shown that the paradox was likely due to using BMI rather than true measures of adiposity. So you can have someone with a normal BMI, but they actually have obesity based upon body fat, but they look like a patient with a normal BMI in these studies. So that's called sarcopenia, when they have a normal BMI, but they actually have increased body fat and actually have a lot of frailty due to that and a lot of metabolic disturbance. Additionally, many of these studies included those who were losing weight due to advanced disease. So that heart failure, that new study or the new guideline that I told you about in the European Heart Journal actually talks specifically about that, and this is here. So for HFpEF, they say that obesity, even at a younger age, increases the risk of heart failure. And weight loss can be very, very helpful with diet, exercise, or pharmacological interventions in patients with HFpEF. Below the line there, we're talking about HFrEF. So weight loss through lifestyle interventions may improve symptoms and exercise capacity in patients with HFrEF and obesity, although more evidence is needed. Non-intentional weight loss, we know, is associated with increased mortality in patients with HFrEF. And trials of weight loss interventions in patients with HFrEF with morbidity and mortality outcomes are in fact lacking. Because these medications are so wildly successful, and because there are more and more indications, and because they are very expensive, and the pharmaceutical companies that make these are making a fortune, you can imagine there are many, many more of these in the pipeline. In fact, one of the ones that we're going to see soon is retatrutide, which is actually a triple receptor agonist, so GLP-1, GIP, and glucagon. So be ready, hold on, lots more are coming. All right, so that's the science. How can you actually do this in practice? What does it really look like? So this is our weight loss program here at VCU. It is a comprehensive, multidisciplinary program covering nutrition, exercise, behavior modification, and medication when indicated. Like I said, it's multidisciplinary. We have many people as part of our team. We are seamless with bariatric surgery. Patients can self-refer to that number right there. However, we're on a pause for taking new patients. So if you have a patient that has urgent needs because they need a transplant or they're very ill, you can refer directly to me and we will get them in. We hope to be open for new patients generally by the end of the year. So this is what I recommend in primary care, how you should approach helping your patients with their weight. First, you want to discuss permission. You want to have permission to discuss their weight. So you want to ask them. And you want to use patient-first language. You've heard me in this presentation talking about patients with overweight or with obesity rather than an obese patient. In primary care, what has happened is we have wound up talking about things like their diabetes, their hypertension, their HFpEF, their knee pain. And oh, by the way, lose weight, eat less, and move more. And I'll see you back in 3 months. And we're shocked when the patients actually haven't lost weight. And if we actually spend more time talking about their weight and how to help them with that, excuse me, we can actually have significant benefit for all of those other diseases that we seem to spend all the time talking about. We want to tell our patients again that just 5 to 10% of their weight loss can have significant cardiovascular benefit. We want to assess all these things here, including looking at their medication list for weight gaining medications. We want to rule out eating disorders, get an exam and some labs, and then we want to assist in helping them formulate a plan that includes all of these things. And then in primary care, we want to follow the patients regularly. And if we're struggling, we want to refer to a higher level of care, like an obesity medicine provider or program, and then consider referral to bariatric surgery if appropriate. In our weight loss program, we do an incredibly deep dive into looking at these things. So we want to know past attempts at weight loss. What did they try? What worked? What didn't? Why did it stop working? We want to do a detailed dietary recall, find out in general, what do they eat for breakfast, lunch, dinner, snacks, drinks? Specifically, what did you eat yesterday? Sometimes those are very, very different. What does the patient think the biggest issue is? Oftentimes they'll tell you. Where do they think the biggest issues happen? Meals, snacks, portions. Do they have a special diet, dietary restrictions, or cultural foods that are very important to them? How often do they eat out? Who lives in the home and who does the cooking? If they cook, what's their skill in cooking? Where do they get the food? Do they rely on food stamps in the food bank? Do they have a scale? And I've listed here at the bottom the National Weight Control Registry. That is a database that keeps track of people who have lost 30 pounds and kept it off for a year or more. And they all have similar behaviors. The top 3 being weighing themselves weekly, tracking their food, and exercising nearly every day, many for an hour or more. You want to find out if the patients qualify and are interested in discussing weight loss medication. And then you want to find out if they qualify, are they interested in pursuing weight loss surgery? And then we screen them for a number of things. We screen them for depression, anxiety, eating disorders, childhood trauma, their readiness for change, emotional eating, an Epworth Sleepiness Scale for sleep apnea, and a Holmes Race stress score. We feel it is very important to get a comprehensive look at the patient to help us diagnose what really is the problem. Oftentimes, the food is not the problem at all, and just helping them change their food is not going to help them be successful in the long term. So that's a lot. You're probably thinking right now, oh my God, I could never do this. I could never have that much time because we're worried about all their cardiovascular problems. So do I think you could do this in your clinic? I do. But I think there are some things you need to know about your patients before prescribing. So this is the bare minimum I think you should know before prescribing. And the question is, will it be different what you need to know if you're prescribing for obesity versus prescribing for a cardiovascular indication? Does it matter? I don't really know the answer to that question, but probably not. So you definitely need to know what they're eating for breakfast, lunch, dinner, snacks, and drinks, including alcohol. So it's not just the sweet tea or the soda. You need to know about their drinking habits for alcohol. And my colleagues and I will tell you, it's not uncommon that we find that the real problem here is an alcohol use disorder. And if we find that, we do not attempt to help them with weight loss. We help them get help with their alcohol use disorder. And when that is under better control, then we can focus on their weight. Are they on birth control? Are they breastfeeding? Are they planning on getting pregnant? It would be a very bad idea to start them on these medications only to take them off because they are planning to get pregnant in the next year. Are you going to be able to follow them on these medications? Do they have an eating disorder? And even though we use a very comprehensive eating disorder screen, there's actually a very simple one that you can use, and it's called the SCOFF. So the SCOFF, now it is British. So do you make yourself sick because you feel uncomfortably full? Do you worry that you have lost control over how much you eat? Have you recently lost more than 1 stone? There's the British part, 14 pounds in a 3-month period. Do you believe yourself to be fat when others say you are too thin? And would you say that food dominates your life? Now, if they have a score of 2 or more, that's actually 100% sensitivity and almost an 88% specificity for anorexia and bulimia. Now, this study was first done in younger women, but it's been revalidated, and I actually have that here. The U.S. Preventive Services Task Force actually does recommend this screening. It's been validated in many other populations as well. So you can see that this is fairly quick and easy to determine if the patient has an eating disorder, and that would not be somebody you would want to put on these medications. They will need a referral to a higher level of care. So what about bariatric surgery? Do they qualify and are they interested in bariatric surgery? So it's important that you understand those qualifications. And I actually had to change this slide yesterday because it's always been for decades a BMI of 40 or more or 35 with a weight-related complication. However, in the past couple of weeks, more and more insurance companies are now allowing a lower BMI. So a BMI of 35 or more, or 30 with a weight-related complication like diabetes, hypertension, or sleep apnea. They have to be an acceptable operative risk. Generally, that's going to be less than 65. But those who are fairly healthy over 65, they certainly qualify and they do surgery. I've seen up to 75 here. But even if they're younger, they have to be healthy enough for surgery. But they do surgery on some pretty complicated patients. All right, I'd like to drive another point home with this case. So this is a 36-year-old African-American female with prediabetes, hypertension, HFpEF, depression, and class 3 obesity. You are seeing them and you have prescribed semaglutide for them. So now you're seeing them in a 3-month follow-up for their HFpEF and obesity. The nurse has called her monthly to see how she's doing and has helped you titrate the doses, and the patient is now on semaglutide 2.4 milligrams. So you last saw her in person 3 months ago, and now you're seeing her, she's at the maximum dose of 2.4 milligrams. She's very excited about her weight loss, and when you get a dietary recall, for breakfast, she's eating an egg, she's skipping lunch, and for dinner, she's eating a sandwich. She's drinking 16 ounces of water and 1 diet soda a day. But she tells you something very odd is happening. She actually really can't eat beef anymore. It just makes her nauseous thinking about it. And you realize she's only getting about 15 grams of protein in a day. But she has lost 40 pounds. Woohoo! So she's very excited. All right, so let's talk about dose escalation. What is the right dose of these medications? So the overall consideration is that you're going to dose escalate monthly. I highly recommend that you do not send all the doses to the pharmacy and let the patient self-escalate. At each escalation, you're going to ask about side effects and what they are eating. And you need to balance the decrease in appetite and cravings and weight loss with side effects and the ability to eat enough healthy food. I also prefer to be less than the maximum dose because of metabolic adaptation. So I feel it doesn't matter what you do to lose weight, whether it's weight loss surgery, medications, in addition to always lifestyle changes. Over time, metabolic adaptation is going to start pushing against your weight loss. And so hunger and cravings are going to increase. And I like to have another dose in my back pocket. So what's going to be your plan? Because you've come to my presentation, you feel really comfortable in changing the plan. You're going to re-educate her about the minimum need for her protein needs, with a minimum being about 64 grams in a day, probably more like 90. Increase her fluid, 64 ounces in a day. And again, you want to reemphasize strength training so she doesn't lose as much muscle mass. You're going to reduce the semaglutide, and because you're really worried about her, you're actually going to have a virtual follow-up with her personally in 1 month. If she continues to have problems, you will continue to dose de-escalate or switch her to a different medication, and you may have to stop it completely. This also, if you continue to have a problem, may need to be a patient that you refer for additional care. I just want to say something very about a medication. So I know that there's a lot of prescribing of SGLT2 inhibitors. And I see patients come to me a lot on these medications. Of course, they have a risk of ketoacidosis alone. I never prescribe a ketogenic diet in patients on SGLT2 inhibitors because I think that increases their risk of ketoacidosis. But if they're eating very little, it's very possible, without even prescribing a ketogenic diet, that they are actually in ketosis. And I think that's a very big risk. So I would look very carefully with your patients. I would think that would be another medication that you will have to look at and depend upon their weight loss and what they're eating, if that's a good medication to continue, or if you need to change the injection medication. All right, so how are you going to follow up these patients on these medications? You need to see them frequently, every 1 month while titrating, then every 3 months. Does it have to be done by you? Could it maybe be done by one of your colleagues, like a nurse practitioner, or one of your nurses that's calling the patient every month and sending you this information? But the patients need to be followed every month while dose escalating, and then every 3 months until they're at a stable dose for a while. You want to make sure that these medications are effective at weight loss. So again, if they're not losing weight, then you need to take them off the medication, change to a medication. There are some people who are non-responders. You want to make sure they're effective at craving appetite reduction. Again, you want to make sure that they don't plan to get pregnant. They're continuing dual contraception as they are dose escalating if they're on oral birth control pills. You want to check for side effects, mostly GI, and constipation seems to be the biggest one, and you really want to stay on top of the constipation. You also want to, again, look at their other medications to see if you need to make some dose changes in those. Again, you want to get that dietary recall carefully. Some people are not eating and they think that's okay. Check their protein intake, make sure they're getting a minimum of 64 grams of protein, 64 ounces of fluids. Check their exercise plan, and determine whether they might need a referral to a higher level of care. How do I think you can do this in cardiology? So I do think that you can do it, but it's going to have to be done thoughtfully. You're going to have a team. You're going to have a relationship with dietitians, because you're probably not going to do the dietary counseling yourself, although you certainly can do some and reinforce when you see them. You want to have a relationship with mental health providers. If your patients are not doing well, they may need to see them or come to a higher level of care. Again, maybe a nurse, a pharmacist, or a nurse practitioner that's really interested in this, that can help you up titrate the injection medications. And you're going to need someone to do your prior authorization. So you may have someone in your clinic already helping you with some of the more expensive medications you use. We use a specialty pharmacy for all of these medications when the patient's insurance allows. You may develop a relationship with them, and I'd be happy to set you guys up to have that conversation. They help me dose escalate the medications. They are amazing. We're actually in the process of hiring our own pharmacist that can really help us even more, since we do this all of the time. Smart phrases and electronic questionnaires can really help the patients, help the patient, where you're able to capture all this information and you don't have to actually sit and ask the questions within the context of your visit. And we do a lot of this. We have very large electronic questionnaires that the patients have to fill out before they see us initially. And you can have the dietary recall that they do before they even walk in your office, that SCOFF questionnaire for follow-ups, diet recall, questionnaire for side effects. And then consider virtual visits. You can have very quick and effective virtual visits to do some of these things in 10 minutes, see how they're doing, where they don't have to come in and have a, park and do a prolonged visit with you. So this was the perfect picture that I found to tell you how I feel about insurance coverage for these injectable AOMs. So only about half of commercial insurances cover them. Medicare does not, as I talked about already. So be very mindful if you're doing this for obesity without a known cardiovascular disease. And they're very specific. Like, it can't be that they have something seen on a coronary calcium score or a CT scan. It actually has to be a heart attack or a stroke. That's what most Medicare insurances are requiring, or peripheral arterial disease. So careful if someone's getting close to Medicare, like within the next year. You may not want to put someone on only to rapidly rip it away, because remember that rapid weight regain. The Affordable Care Act does not cover these medications. They all require prior authorization, which can be a very tedious back and forth process. Certain insurances require step therapy, some that require oral medications before even going to injection medications, some that require a certain injection medication before going on to another injection medication. And one of my biggest frustrations, you may not be able to continue this medication if not on a maintenance dose. So despite me being the expert and thinking that I want the patient on the lowest dose of this effective medication, if they're not actually on what's called the maintenance dose, the insurance company may refuse to continue the medication. Medicaid, if you ever have a Medicaid patient, we are fortunate that Medicaid does cover these medications. However, they just recently changed the guidelines to be far more restrictive. And so I have that here, and I actually have the prior auth form at the bottom. Medicaid does cover now Wegovy for obesity and known cardiovascular disease. Here is the prior auth, but you will be really happy to know that these can only be prescribed now by a cardiologist or a vascular specialist. I don't really know what that means. So if I have a patient with known cardiovascular disease on Medicaid, I'm going to have to refer them back to you to get on this medication. And here's what they specifically require. Because of differing insurance company coverage and shortages, I am often playing the game of whack-a-mole with these medications where I have to change from one to another. So this dose equivalency table I have on my phone, and I refer to it at least daily. So I've given it to you. Because these can be life-saving medication, everybody is talking about them, and there's not great insurance coverage. People are desperate to get on these medications. And so pharmacies are compounding pharmacies are making these medications. And they're allowed to do that actually when medications are listed on the FDA drug shortage list. All three of the injection AOMs are currently on the FDA drug shortage list. However, I do know for a fact that tirzepatide actually has gone to the FDA to say, we no longer have shortages. And I believe that's the same thing with Novo as well, very shortly. So shortly, companies are not going to be able to, or compounding pharmacies are not going to be able to make this medication. I should also say that medications produced in compounding pharmacies, the actual medication is not checked there for safety, efficacy, and purity. So that can't be guaranteed. And because they're in vials rather than auto injectors, there have been a lot of medication errors and people harmed, winding up in the emergency room and hospitalized for overdosing on these medications. Now, if you do want to think about using a compounded pharmacy, and I have not done that to this point, here I believe are some guidelines, and this particular journal reference here has very specific things that you should, if you are going to use a compounded pharmacy, look for. You should be calling the pharmacy, making sure they send out their products for certificates of authenticity and a whole bunch of other things. But generally, caution should absolutely be used before using a compounded GLP-1. So in summary, obesity is a chronic disease, should be treated as such. We all need to be part of the solution. Lifestyle changes remain the foundation of treatment. New anti-injection obesity medications are safe and effective, but we're always learning more, and they need appropriate monitoring and follow-up, and know when you should refer. And this again comes from that European Heart Journal. I think it really said it perfectly. In the context of interdisciplinary approaches and comprehensive multi-level obesity treatment strategies, cardiologists should become involved in encouraging access to structured anti-obesity programs, surgical treatment whenever indicated, and potentially newer pharmacotherapies according to local availability and resources. It should be appreciated, however, that lifestyle interventions remain first-line treatment for prevention of weight gain and for weight reduction, and that the effects of pharmacologic and lifestyle interventions on weight loss and cardiometabolic factors are additive. Therefore, drug treatment should be used on a complementary rather than a substitutive treatment option. In this case, long-term adherence to a healthy lifestyle remains critical in order to potentiate and maintain favorable drug effects. If you want to get a little more comfortable in prescribing these medications, the Obesity Medicine Association actually has a 2-day virtual course, which is really excellent. And then if you're absolutely overwhelmed and enthralled and excited to treat patients with obesity, you can actually become board certified in obesity medicine. It is a CME pathway, and this is where you would go to look for that. So with that, I'd be very happy to take questions.
Thank you, Dr. Wolver. That was an excellent presentation on obesity, the issues, and really defining the problem, as well as current therapies available. With that, I'd like to open the questions to the audience, and if not, I have questions as well.
So I am going to stop sharing so I can see everybody.
Susan, fantastic talk. This is Greg Hunley. Quick question. In terms of body fat distribution, sometimes we think of intra-abdominal fat, we think of subcutaneous fat, intramuscular fat. When starting some of these injectables, have studies been performed to look at which fat depots tend to decrease more than others? And then you mentioned the rebound phenomenon. Are there certain areas in the body where the fat reaccumulates? Is it replacing kind of where it came from originally, or is it deposited in different areas?
So that's a great question. And certainly obesity medicine physicians usually use a body composition scale. And we have one at all of our sites, and we do that. And we're looking at it far more closely now than we ever used to because of exactly that problem. So if you're losing weight and you're losing muscle, you're not helping anything, right? And you're not even helping, cardiometabolic disease. And for some people with these rapid weight loss, we do see a rapid reduction in muscle. And what I didn't know before getting into this space is that for every 10 pounds of muscle, every 10 pounds of weight someone loses, they automatically lose about 3 pounds of muscle. That's without any medication. With the medication, some preliminary studies look like it might be 4. And so that's why we're really encouraging increased protein intake, strength training to try and preserve some of those muscle. Due to a shortage of time, I didn't talk about the fact that there are actually medications in phase 3 trials right now to increase muscle mass. And they're actually looking at combinations of these anti-obesity injection medications with these new medications to help preserve muscle mass. The unfortunate truth is when you gain weight, you don't gain the muscle back as much as gaining the fat back. So that's why weight cycling is very, very difficult, because you don't gain your muscle back, and you don't generally gain your metabolism back to where it was when you first started. So great questions. And I think the answers are not yet in the literature enough, but we are certainly looking at these things.
Thank you.
Thank you, Dr. Wolver. We have a few questions in the chat I'd like to bring attention to. So Christine Browning is asking, is obesity board certification open to APPs or perhaps a different educational pathway?
Right. So the American Board of Obesity Medicine is only open to board certified physicians in any specialty. However, APPs through the Obesity Medicine Association, which was the slide prior to that, does have a certification pathway for APPs.
Thank you. And then Dr. Ye is asking, what is your insight into the increasing incidence of obesity over the years and population-based efforts to address these root causes?
How much time do you have? So I believe personally, this happened when we started with the low-fat guidelines, and we came up with a food pyramid that said eat the majority of your diet from sugars and starches. I'm not going to bring up my slides, but if you go back to that European Heart Journal slide where I talked about all of the consequences of obesity on the cardiovascular system, the top part of it talked about the causes of obesity. So it's obviously multifactorial, but I think, our nutrition guidelines are a huge part of it. Money is the other part because, as you know, the minute everyone's doing something, people jump on the bandwagon. So food companies made a lot of highly processed, low-fat foods that everyone is eating. And if you look at when the guidelines came out in 1980 till now, the rates of obesity and diabetes have skyrocketed. We call it diabesity even. And so really that's happened, over the last 40 years. So that's where I think the problem has come from. But it's certainly multifactorial. We're more sedentary and, is it, BPAs and obesogenic plastics and endocrine disruptors and, many, many things. But I think personally, I think the number one thing is the change in our eating. There's a great book called Why We Get Fat by Gary Taubes, and he's a Harvard and physicist that actually is a scientific journalist. And he said that if you take the lifespan of man and put it on a football field, we've changed our diet more in the last 1 yard line than in the entire football field before that in the last 100 years or so. And our bodies have not adapted to all of these changes and we're getting sick. In fact, fewer than 10% of a study in the NHANES database had 0 parts of the metabolic syndrome. So basically, fewer than 10% are metabolically healthy. It's catastrophic. That's why we all have to be part of the solution.
Thank you so much, Dr. Wolver. I have one last question, and then I think we can wrap up. So you mentioned BMI as a general measure, and there are obviously exceptions to that measurement. In the weight loss program here at VCU, do we use additional measurements of BMI in really characterizing obesity, or do we make additional measures or exceptions such as waist circumference to think about visceral or abdominal fat as a better marker?
So that is something that if people don't have a body composition scale, I highly recommend doing in all practices, which is a waist circumference, because that's going to give you a lot of information. We do the body composition scale, but remember, people are coming to us because they want to lose weight. So the waist circumference is really more important in someone with a normal BMI who think that they're metabolically healthy, and they need to know they have increased risk. Time to take action is now, not when you get diabetes or heart disease and things like that. Now, the one time where we really use those other factors is when people are losing weight. They're really focused on the scale. We try to tell them that weight loss is actually a side effect of taking care of themselves, eating well, and moving their bodies, getting good sleep, managing stress. Those are all part of health. We don't focus on the scale, but they are looking at the body composition with what a normal BMI is. And for Black women especially, we say, as long as you're metabolically healthy, we're okay with your being in the overweight category. So it's more when we're going down that we tell them. Now, someone of Asian descent, especially if they have like pre-diabetes, they need to be pushed lower because they have a higher risk of cardiometabolic disease at lower BMIs. So that's where we really use it for where they settle out.
Thank you, Dr. Wolver. Two more questions from the...
Oh, I was going to say, before we go, I'd be very happy to answer these questions after. So if you wanted to capture them in some way and email them to me, I'd be happy to get them. I know I tried to be a little bit shorter because I knew there would be a ton of questions.
No problem, Dr. Wolver. We actually do have 2 questions in the chat, but given what you've said, I'll ask them.
No, I'm very happy to stay on. I don't have a patient for 10 minutes, just for the people that have to go. I'll stay on until my patient's here.
No problem. So Dr. Albna asks, excellent presentation. Thank you, Dr. Wolver. You talk about being careful when prescribing these medications in older folks. Is there an age cutoff where you will suggest not to prescribe these drugs?
So it's not an age cutoff. And again, this isn't in the literature yet. And like the thing about fracture risk is actually just in the drug monograph, which is kind of crazy because I think it's a really big deal and it looks actually pretty significant. So, if I had someone that was seeing me in cardiology, if I was a cardiologist, and their BMI was 28 and they are 72, and I think, oh, they have known cardiovascular disease, let me throw them on this medication because Medicare covers it now, I think I'd be much more concerned. We know that age and weight are tremendous factors in fracture risk. So there's no actual number in my head. You might have a really robust 76-year-old who's, exercising and has a BMI of 37 that might be very helpful to get them on the drug. But I will absolutely make sure that they are prioritizing protein because as you get older, you use your protein less effective, and that they are in that gym and strength training. And then of course doing not only strength training, but training that's going to be good for their bones. So, real, pounding on the pavement kind of things.
Thank you, Dr. Wolver. And we have a question from Amelia Vanderberg-Hanner. She's one of our physician associates in the prevention cardiology clinic. What are your thoughts on the ketogenic diet in relation to cardiovascular disease?
So how long do we have for that? So we do prescribe a ketogenic diet here. I think it's an excellent prescription diet, if you will. I think that there are more and more research. We could do a whole hour just on the ketogenic diet about the actual benefits of the ketogenic diet because it has a very active molecule, beta hydroxybutyrate. Are you hearing all that noise? They're putting in oxygen tanks. Because I'll tell them to stop. If you're hearing all the background noise, you're not hearing it?
No, we're good.
Okay, they're like throwing oxygen tanks in the room right now. For patients that come to me that want to do a ketogenic diet, we do it very thoughtfully. It's a great way to get off of insulin because they're eating fewer carbohydrates. However, to me, the best diet a patient can be on is none. I teach them what healthy food is and tell them to eat that most of the time. If you get on a diet, you get off of a diet. But there's more and more evidence for ketogenic diets for certain conditions like neurological conditions. So patients will come to see me. There was some emerging evidence that maybe even a failing heart does better on ketones. I think I just saw a study that maybe that's not true. I think that it has there's great benefit. More and more research is done for cardiovascular disease, but I can tell you for sure probably the number one risk factor for cardiovascular disease being diabetes. It is magical for diabetes. Almost everybody who comes to me on insulin and wants to do a ketogenic diet comes off of insulin. And that includes, I've taken someone off of 73 units in 5 days, someone on 240 units of insulin in 3 weeks. But it really depends what the patient wants to do and how they want to approach it, because we meet the patients where they are.
Thank you so much for that excellent presentation, Dr. Wolver. Really appreciate your time and your thoughts. If no one else has any questions, I will be ending Grand Rounds. Thank you and take care.
Thank you, everybody, for having me.